How do we diagnose gastroesophageal cancer? In this video, I'm going to go through the steps that are taken after presentation with various symptoms in order to come to and pinpoint a diagnosis of gastroesophageal cancer. In previous videos, we've looked at the three main subtypes of gastroesophageal cancer, from esophageal squamous cell, esophageal gastric junction adenocarcinoma, and then gastric non-cardia adenocarcinoma. We talked about who's at risk for each of these. We talked about the causes of each of these. And now we're going to talk about, as a consequence of presenting with symptoms from each of these, how we can confirm a diagnosis. In the video on symptoms and signs of cancer, we talked about the primary tumor and the symptoms and signs that it can cause, that they can slightly differ from the esophagus to the G junction to the stomach, but overall, each of these symptoms are a consequence of the actual primary tumor in place, which is the most common conglomerate of symptoms that ultimately leads to further testing and an eventual diagnosis. We also talked about how cancer can spread or become metastatic, and that it can spread through direct extension from where it started, or through the lymphatic system or the blood. And we talked about the common sites that it can spread to, most commonly metastatic lymph nodes, both near and far from the primary tumor, the liver, the peritoneal cavity, the lung, and the bone. We also talked about that each of those locations, when it spreads to them, can cause symptoms, and that sometimes the primary tumor can be relatively quiet and not causing many symptoms, but it's the metastatic site that is the heralding problem that brings you to the doctor and leads to further testing. So, irrespective of what the symptoms are, eventually you will get an upper endoscopy or an esophagogastroduodenoscopy, EGD. And the purpose of this is to look inside the lumen of the esophagus. And of course, if there's a mass abnormality seen there, it would be biopsied. If there's bleeding, the endoscopist can do something called cauterization to burn it off and prevent slow oozing. They can also, and we'll talk about in later videos when we talk about palliative therapies, they can dilate the narrowing in the esophagus or in the stomach, and or add a stent to prop that area open. So there's a number of different things from diagnosis to treatment that an upper endoscopy can do. So this is what it looks like. The endoscope comes in through the mouth, down through the esophagus, and into the stomach, and to the far end of the duodenum. And normally, you would see in the esophagus, this is what the endoscopist would be visualizing. And in the stomach, this would be the normal gastric folds without any abnormalities. In the case of when there's a cancer, you can see on the left, there'd be a mass there. In this case, it's oozing, that's blood. Or in the stomach, there's a gastric cancer. This is an obvious, probable intestinal type cancer with a mass forming and the rest of the stomach appearing normal. In some cases, I'll take you through, the endoscopy looks normal, but in the end, there is diffuse type gastric cancer in the walls of the stomach, and it can be somewhat elusive. So other tests would be required to confirm a diagnosis in some cases. Regardless, if an abnormality is seen, the endoscopist takes a biopsy, and one of the first things that we do after it's sent to the pathologist will tell us, is it an adenocarcinoma or a squamous cell cancer? And we talked about that in the what and where is cancer, and the importance of this in terms of what is the etiology of this cancer, but also downstream what that prognosis and the treatments would be, which would be slightly different in this case. And so this would usually be a distinction of adeno versus squamous cell when it's in the esophagus, in the middle to lower end of the esophagus. If it's upper esophagus, it's almost always a squamous cell. And if it's in the stomach, it's usually an adenocarcinoma. It's just in the esophageal area that this would really be a distinction that we'd be looking for. If it's in the stomach, we talked about the differentiation between an intestinal type cancer versus a diffuse type cancer, and the pathologist can tell us the difference. Sometimes there's features of both. And we've talked about some of the genetics that would lead to the differences of how this would appear under the microscope. The pathologist would also tell us the differentiation of the tumor. And what that means is um, there's a gradation scale that's a continuum from being well-differentiated cancer to poorly differentiated cancer. And what it means is the well-differentiated tumor cells look almost normal, but they do appear abnormal. And then as you go down the spectrum from well to moderate to poorly differentiated, the cells become more and more abnormal looking. And historically, the reason why the pathologist tells us this is that generally the poorly differentiated tumors tend to be more aggressive and therefore may have a worse prognosis. But overall, this really doesn't dictate what treatments are going to be based on what the differentiation is, but it is a piece of information that is obtained at the time of diagnosis from the pathologist review of the biopsy sample. So in addition to an upper endoscopy, we would be doing a CAT scan. And usually this is after presenting with usually localized symptoms that lead to an upper endoscopy first and confirmation of a biopsy of cancer there. And a CAT scan is then done to evaluate other sites if there are other sites of spread of the cancer to distant spots. However, as I mentioned, occasionally the heralding symptoms are from symptoms from a metastatic lesion like abdominal pain in the right upper quadrant that ultimately ends up being from a liver mass. And so a CAT scan would be done and could identify such mass. And then we would be working backwards to try and identify where this mass came from. Did it start in the liver or did it start elsewhere? And we would be really narrowing down, is an upper endoscopy necessary? Are there local symptoms, even if vague? Or is there another reason to be doing an upper endoscopy and pinpoint backwards manner where it came from? What is a CAT scan, a computed tomography? It's basically three-dimensional x-rays. And there are two contrasts that are usually given with it in the setting, particularly when we're looking at gastroesophageal cancer. And one is intravenous contrast, IV contrast, which helps to highlight the primary tumor, any abnormal lymph nodes throughout the body, abnormalities in the liver, for example. In addition to that, we give an oral contrast that you drink before the CAT scan, and that goes and highlights the whole GI tract and helps the radiologist to identify if there's an abnormality within the lumen of the tube and helps to differentiate the gut from other structures in the abdominal cavity. So this is a CAT scan that's normal of the esophagus and of the stomach. So just briefly, a CAT scan, this is if you were lying on your back, this is your upper, this is your front, this is your back, this is your left side, and this is your right side. And this is a cross section through, in this case, the chest cavity. So anything black on a CAT scan is air. And so these are your two lungs. And this is your heart in the center of your chest. This is the aorta, a large blood vessel. And the esophagus is barely visible here. It's just a little tube that's barely visible. And in a cross section through the abdominal cavity would show different structures. In this case, it shows the liver, which is homogeneous, all pretty much one color, except for a few blood vessels, these white dots, the gallbladder, the bowel. This is all small bowel filled with the oral contrast that highlights in white on the scan. And this is the normal stomach with contrast that the patient has swallowed, and as well as this air bubble that's inside the stomach. So a normal thin stomach, a normal esophagus. These are called axial views that do a cross section through the body in this dimension. This is a normal view that's called a coronal or frontal view. So it's looking in a different plane. So this is the chest cavity with the two lungs, the heart structures, the esophagus that runs through. And then this is the abdominal cavity with the liver here, the stomach, nice thin stomach, a spleen, the small bowel inside. This is the colon, and bones are white. Muscles are usually gray. And these are, say, for example, your ribs. So this would be a normal CAT scan that the radiologist is looking to compare to and when you're coming in and getting a CAT scan for various reasons. So in the case of where there's a mass in the esophagus, compared to normal, the radiologist can identify readily this abnormality here, that's this mass with the lumen of the esophagus here, so clearly different than normal. And similarly on the frontal view, you can see in comparison to this normal area that the esophagus is abnormal here, this thickening just above the diaphragm inside the thoracic cavity. So this would be an esophageal cancer. When looking at the stomach in comparison to a normal stomach, the radiologist can identify this abnormality on one side of the body of the stomach. And I showed a CAT scan in the video on diffuse type gastric cancer with CDH1 mutation, showing complete thickening throughout the stomach. And so I'm showing extreme examples where the CAT scan can identify abnormalities in the esophagus or stomach. It's not uncommon, though, that the mass is actually relatively small and the CAT scan can't really see it very well. So the sensitivity of looking at the primary tumor isn't as high as we would like. It can pick up obvious large things, but if it's small, it may not be able to identify it. And this is not the most sensitive way to identify the gastroesophageal cancer. It would be to do an upper endoscopy and look inside. So then this is the frontal view showing a normal esophagus and stomach. And then in this video, in this picture, this is a thickened upper stomach and extending up into the junction of the esophagus. So it's very common presentation and appearance of what this would look like on CAT scan. In addition, as I mentioned, CAT scans are used at the time of diagnosis to help with identify whether or not the cancer is spread. And in these examples here, we're seeing an esophagus versus a stomach cancer. And in the liver, which should all be this color, we're seeing not only the primary tumor in the esophagus here, that's abnormal, and then this is the stomach highlighted with the oral contrast, but we're also seeing these dark, or what are referred to as hypodense spots or lesions in the liver, a number of them. And so these would be consistent in this case with a spread from the primary tumor to the liver through the venous system. And in this setting, it's generally accepted that this would all be concordant and consistent with this cancer. If this cancer was biopsied here by an endoscopy, then it would not be necessary per se to biopsy each of these or any of these to confirm that it has spread there. This would all be very consistent with spread from the esophageal cancer. Later on, when we talk about molecular testing and the genetics of the cancer, there is rationale and reason to consider biopsying distant sites, or at least assessing the distant sites through various diagnostic tests, because occasionally there can be different genetic mutations that, in the metastatic sites compared to the primary tumor, that then would potentially lead to differences or new options for targeted therapies. So something to be aware of there. But in terms of making a diagnosis, it's not necessary to confirm that these obvious masses are as a consequence of the primary tumor. Occasionally, there's maybe just one spot and it's not clear. The radiologist isn't certain that it's abnormal. In that case, then it might be reasonable to go and biopsy one of these other spots to see if it has or has not spread to the outside organs, in this case, the liver. On the right side, we see multiple spots that are from this the stomach. In this case, the stomach doesn't look that abnormal. And this is an example of potentially where the patient may present with right upper quadrant pain, because liver masses can sometimes be painful or cause discomfort. And so the first thing that would be noted abnormal is this abnormality in the liver. And then we would be trying to track down where did this come from, and then doing an upper endoscopy after the CAT scan in that particular sequence of events, which is not uncommon. But the most common presentation would be a primary tumor symptom leading to an upper endoscopy, and then doing CAT scans to complete staging. So in addition to the endoscopy and the CT scan, particularly if the CT scan does not show any spread outside of the primary tumor, Then the next test that would be done at diagnosis would be an upper endoscopic ultrasound. And the reason that this is done is usually to help get a sense of how far through the wall of the esophagus or the stomach the mass is invading, which is called the clinical T stage or the tumor stage, and abnormalities around the tumor. Are there abnormal lymph nodes? And they'll give us the clinical nodal stage. And the reason why I included here at the time of diagnosis, occasionally an upper endoscopy is not a conclusive. It's inconclusive to confirm a diagnosis. It looks normal inside the stomach, and random biopsies in the stomach do not show or confirm that there's a cancer. A CAT scan doesn't show any abnormalities anywhere, including in the stomach, but there's still persistent symptoms of abdominal pain, for example. And so in that setting, and what I'm alluding to is a diffuse type gastric cancer, which is inside the wall of the stomach, but often can be elusive from some of these other tests. An endoscopic ultrasound can look at the thickness of the stomach and also put a needle into the wall of the stomach called a fine needle aspiration, FNA, and get sample to confirm that there's a diagnosis deeper down inside the wall of the stomach. So an upper endoscopic ultrasound is very similar to an endoscopy or EGD. In fact, usually if an EUS is being done, an EGD is by default also done, which is just looking inside. But then the endoscopist will change the probe at the end of the endoscopic tool. And on the end of the tool, there is an ultrasound probe. And so this ultrasound can evaluate and look at this cancer lesion in more detail. So what this is showing is if this is the esophagus and this is the probe going down through the esophagus, and this is a cross section through the wall of the esophagus, the ultrasound can help to look at the different layers from inside to the outside of the esophagus, like an onion layer. And each of these layers has a name. And so the mass of the tumor can be evaluated to see how far and how deep through the wall is this mass invading. In addition to that, as I mentioned, the endoscopist can evaluate regional lymph nodes. So if this is inside the esophagus, these are the different layers, and then this is outside of the wall of the esophagus in the fatty tissue, and there's an abnormality in the lymph node, they can quantify how many abnormal lymph nodes are nearby. If they're suspicious but not sure, they can actually stick a needle through there and take a sample of that lymph node. And then in the example that I was mentioning in diffuse type gastric cancer that has been elusive and a diagnosis has not been made yet, but there's a concern on endoscopic ultrasound, one can go in and put a needle with a fine needle aspiration into the wall of the stomach and get a biopsy of that sample and confirm that there are abnormal cells there, even though the endoscopy looks normal on the surface and superficial biopsy of the stomach are coming back normal. And then, of course, the endoscopic ultrasound can go all the way through to the end and actually look nearby in certain areas of the liver nearby to see if there's any abnormalities there. So the endoscopic ultrasound tool is mostly for staging, but also can help confirm a suspicious diagnosis that has been elusive up to that point. PET scans are another tool that's used, and an FDG PET or fluorodeoxyglucose PET is a different type of scan compared to a CAT scan. It's what I consider a complementary scan to a CAT scan. And the way it works is, as opposed to the scan looking at the sizes of the masses and actually measuring them on the scan, or looking at the thickness of, say, the GI tract, like the esophagus and stomach, the FDG PET basically infuses a radio-labeled sugar, glucose is sugar, that goes through your body. And anything that's using that sugar at a faster rate than normal or than other things will light up. And so examples of normal things that use sugar at a higher rate than average is, say, the brain. And so on a PET scan, the brain is uplighting significantly, as I'll show you. On the other hand, cancer cells are metabolizing sugar faster than normal cells, and so they will uptake this and concentrate it there, and then it will light up in those locations. And so PET scans are usually done after these other tests are performed and to confirm that there is not any distant metastatic disease before proceeding to therapy for the localized cancer. In other words, going down a surgical path. It can also be used to look at how treatment is working, to look at the uptake activity before and after treatment. Usually, if treatment's working, it'll decrease, as I'll show you. But it is also in the setting of where, again, there's a situation where we found masses, say, in the liver through symptoms that led to a CAT scan, and now we're trying to identify where the cancer came from, and it's not obvious. Often a PET scan will be done because we would usually be able to see the abnormal uptake of PET in the liver masses, but also it would look at and I highlight the abnormality in the primary tumor. And if it's coming from the stomach or from the esophagus, then it would be readily apparent, as I'll show you. So it can be used as a diagnostic test in the setting of where we're not sure where a primary tumor is, for example. Some things also to note about FDG PET is that diffuse type gastric cancers or mucinous cancers under the microscope are often negative on the PET scan. Even though there's cancer there, the PET scan doesn't detect them. So they're not really that sensitive for diffuse type gastric cancers. Similarly, they're not very sensitive for peritoneal disease inside the belly cavity. And as we'll talk about, why we do diagnostic laparoscopies in the setting of CAT scans and PET scans being normal for metastatic disease, there's still a chance it could have spread to the peritoneal cavity because the sensitivity of PET scans and CAT scans for peritoneal disease is not as high as we would like it to be. So these are examples of PET scans, and the way PET scans work, this is superimposed on a CAT scan, and anywhere that you see highlighted uptake would be where the radio-labeled sugar is concentrating. And that's measured in terms of standardized uptake value, so it can compare from one scan to the next. And so things to note are that there are some normal areas that this will uptake on a PET scan. So these are the kidneys, and so this is where the blood is filtered, and then urine comes down the urine duct and collects in the bladder. And so this is how a lot of sugar is excreted. And so we will see this normally in every patient that gets a PET scan. Similarly, as I mentioned, the brain will have high uptake, and so you can see high uptake on this sagittal. Sagittal means from the side view. So the frontal view, the sagittal view, side view, and then the axial view of this PET scan will see this one abnormality that's right in the lower esophagus, in the mid to lower esophagus, in the thoracic cavity, and this is an esophageal cancer that is uptaking abnormally on this PET scan. As I mentioned, the PET scan is more often than not used to help stage the cancer, and so we see this abnormal uptake here, which is consistent with the primary tumor, but then there are abnormalities in what would be referred to as distant metastatic lymph nodes, the supraclavicular lymph nodes, which is a very common location to spread, potentially even in the bone here in the vertebral body, and also to upper abdominal, retroperitoneal, and celiac plexus lymph nodes. So a staging tool to look at distant sites. Similarly, this can pick up uptake in the liver, which is shown here, and these dark black spots would be consistent with spots in the liver. And what we're doing here with these three different views are coming through at different planes through the body from back to front. And as you get a little bit more to the front, you can see this esophageal mass that's abnormal uptake. The reason why these two look different is just the technique that the PET scan is using. And so the radiologist will look at all of these types of views and come up with an answer. But even for an untrained eye, we can see the abnormal esophagus mass and the abnormal spots here in the liver consistent with metastatic disease. I mentioned that the CT and PET scans can be used before and after therapy to see how therapy is working and to evaluate interval changes. And so this is the baseline here shown here on the frontal view, on the axial view, and then on the CAT scan as being abnormal. and then after, and it's measured with this SUV, and then after treatment, we can see that the uptake in the primary tumor is decreased. It's decreased, but not completely gone. And the size of the mass is also slightly smaller. So the CAT scan and the PET scan are complementary, again, here showing the size of abnormality and also the uptake, the activity of the cancer, both in this case shrinking, which is a good sign. So in addition to the endoscopies, the CT scan and PET scans, we also would be getting serum tumor markers at diagnosis, and typically they are the CEA and CA19-9. You can see here on this table that there are a number of different tumors, so-called serum tumor markers. And although this table suggests that they seem to be unique for various cancer types, the most important thing to take away is that these tumor markers are not specific to any cancer, and that they can be elevated across various cancer types. So as an example, even though CA19-9 here is listed as pancreatic cancer and CEA is listed as colon cancer, these are very often, if not almost always, up one or the other one up abnormally in gastroesophageal cancer. So for the most part, these are the two that would be used. Others could be elevated in gastroesophageal cancer, like AFP, some of these other antigens, CA27, 29, and CA125. So in the end, we don't check all of them. For me, in my practice, and in most, CEA and CA19-9 are the most common ones to use. So CEA is carcinoembryonic antigen, and CA19-9 is carbohydrate antigen 19-9. And every lab will have normal ranges. These are examples of that. They may slightly differ from one lab to the other, but overall, this would be similar in terms of what would be the upper level of normal. And so normally these antigens would not be expressed in normal cells, but in cancer cells that become abnormal, they become what's called dedifferentiated, and they start to excrete things that they normally would not. In this case, many of them are excreted at the time of development in embryos, and then sort of go quiet and are not elevated anymore in the adult. But then cancer cells sort of revert back and start to excrete these things. So these would be the two values that we'd be looking for. And as I was alluding to, one or the other or both sometimes are not elevated in every patient's cancer, even in gastroesophageal cancer, even at diagnosis or throughout treatment. Now, we'll still check it occasionally in that setting just to see, because sometimes they do start to elevate over time. But certainly if there are some cases that are very commonly always normal and low, and that would be, again, that notorious diffuse type cancer and closely related peritoneal only cancer just doesn't excrete these often into the peripheral blood. So they can be completely normal in the setting of a known diffuse type or peritoneal only cancer. But if one or both are elevated, they can be useful, first, of course, to confirm the diagnosis that's based on all the other tests that we've been talking about. But usually and mostly, these tumor markers are used to trend and evaluate response to therapies. I showed how we trend CAT scans and PET scans, but also tumor markers can be helpful to evaluate if therapies are working. So an example here is showing in a case where the CA19-9 in blue was extremely elevated at diagnosis, whereas the CEA was completely normal. And then over time, usually this little bump is as we're waiting for getting therapy started, and then this is the first day of therapy, and then you can see the response. It's not uncommon, though, that we do see an uptick even after therapy starts and then dropping. And then this is an example of the reciprocal, where the patient had completely normal CA19-9s, but the CEA was elevated at 15 and then dropped with therapy. So this is usually how serum tumor markers are used, is to trend over time, but certainly the baseline check is helpful in terms of confirming the diagnosis. So we went through the endoscopy, the CT scans, the PET scans, and then tumor markers. And one other thing to mention here that we'll talk in more detail in later videos is a diagnostic laparoscopy that's performed particularly for staging into complete staging, because, as I mentioned, CT scans, the endoscopies, and PET scan can often not identify occult peritoneal disease that's there, but just going under the radar and we can't detect it. And so a diagnostic laparoscopy is performed if all of these other tests are looking like it's just a primary tumor in the esophagus or G junction, excuse me, the G junction of the stomach. And just to confirm that it's not there, a diagnostic laparoscopy would be performed. And we'll talk about that in other videos. And then finally, at the time of diagnosis, there are a number of standard routine molecular tests that are performed. We're going to have dedicated videos later about these, but just to be complete here, because many of these tests are just done routinely by the pathologist at the time of diagnosis when they see that there's an esophagus or stomach cancer, and that includes HER2 testing, MSI testing, PD-L1 testing. There will be claudin testing coming soon based on the positive randomized phase 3 study. And next generation sequencing is becoming more and more common in terms of trying to identify a number of genetic events and other genetic events that all have implications on therapy. Some of these tests by immunohistochemistry and FISH are redundant with the results that come to us from next generation sequencing. Next generation sequencing usually takes 2 or 3 weeks to get back. Immunohistochemistry usually takes 3 to 5 days to come back. And so we can get a lot of this information a lot quicker from these routine reflex tests, and at the same time sending off gene sequencing to come back at a later date. There are some other tests that some centers do. We do not routinely do our EBV testing. But overall, the reason that these tests are done is because at the moment, in January of 2023, there are some major molecular subsets of the disease that then have implications on therapy that we're going to go through. One is HER2 positive disease. One is HER2 negative, PD-L1 positive disease. I use a cutoff of combined positivity score of 10 or higher. Others use 5. We'll talk about that at later videos. Then HER2 negative, PD-L1 negative, and then claudin positive versus claudin negative. And this is as a consequence of a positive study that just came out called the Spotlight study that we'll go through in detail when we get to treatment. So these are the main subsets of the disease that then have different pathways in terms of therapy. There are some other subsets that are a little bit redundant because MSI high are usually very highly PD-L1 positive. EBV positive are usually very highly PD-L1 positive, and high mutation burden is not really something that I would act on, at least in the early setting in the first lines of therapy. And then differentiating between high mutation burden and what its PD-L1 score could be of use. But overall, there's really these 4 major subtypes at the moment that then would dictate different treatments. So overall, we talked and went through the steps on how we diagnose the cancer after presenting with various symptoms. We talked about endoscopy, upper endoscopy with an ultrasound, CAT scans, PET scans, tumor markers, diagnostic laparoscopy, and other molecular tests on the biopsy sample, all of which are getting us poised to first getting to a stage, and then which will help us with prognosis and also will dictate treatments. So stay tuned to the next videos where we will focus on how do we stage the cancer, and the next video, what does this mean and what does it mean in terms of prognosis. So stay tuned.